Oh, sweet, thank you. All right, so that's me. I have a lot of slides with a lot of detail, and I tend to kind of whiz through them a little bit and have this a little bit more of a conversation than a lecture. So if I say something that strikes a little interest, please feel free to interrupt me. A lot of the stuff I'm just going to gloss over the detail and talk about some of the more just sort of overview, but if we want to delve into the detail, there's some pictures that I can refer to. So I'd ask you to bear with me. I'm losing my voice a little bit. I'm not sure why. It might be the ragweed or something. I don't know. Someone said it's real bad. But I'm going to do the best I can. This is my third talk in 2 weeks, so I'm starting to lose it a little bit. So what I'm going to do is I divided my talk into 4 parts. We're going to talk about what's new in the diagnosis of Parkinson's disease and what we understand about what causes Parkinson's disease, neuroprotection trials. These are things that may cure or slow progression of the disease. And then finally, we'll talk about the new treatments that are available and kind of what's on the horizon. So we're starting off just talking about diagnosis. So those of you who have Parkinson's probably know this pretty well. There is no test that you can take that definitively tells you that you have Parkinson's disease. The disease is made clinically. The way we make a definite diagnosis is actually examining the brains of people who may have Parkinson's under the microscope, and we look for particular pathology. So one of them is something called the Lewy body, and you'll hear me talk a lot about that. This is stained with something that looks for ubiquitin, which is a protein that's present in this little pathological lesion. This is inside a cell, and synuclein is also there. If it's not really stained for protein, it just looks pink in tissue that's stained in a particular way to look at pathology in the brain. So when Parkinson's disease was really first understood on the pathological level, people looked for the presence of these Lewy bodies. They also looked for the loss of pigmented neurons in an area of the brain called the substantia nigra, and that just means black substance. So there's an area of the brain that's pigmented. It's like a tan, it's like melanin, like what makes our skin tan, which I got a lot more of this weekend actually. And it's all in here, and these cells make dopamine, and these cells ship the dopamine up to areas of the brain. In Parkinson's disease, what really makes the motor symptoms, the tremor and the slowness, is the loss of these cells. This area becomes more pale, and you don't get as much dopamine. Now, there's all kinds of other things that go on in Parkinson's disease, but this is the feature that really generates what we think of when we think about Parkinson's: the tremor, the slowness, and the rigidity. So that's how we make the diagnosis. And we talk about Parkinson's disease. Parkinson's, a guy who lived in the 1800s, who saw 6 people and decided that he would define this as a disease. But Parkinson's disease itself was probably described thousands of years ago in old Indian medical texts. And what's fascinating, to me anyway, is that there was a treatment for this condition way back when, thousands of years ago. So they described people who had a stare, so they wouldn't blink their eyes as much. They had tremor, a little bit of excessive saliva, all these things. And there was a plant called cowhage or velvet bean. We call it Mucuna pruriens is the Latin name for it. And you can still buy this stuff, and you know what's in there is levodopa. So thousands of years ago, these doctors practicing in India actually knew about this disease and how to treat it. I don't understand how this even happens, but it's just amazing. But then in the 1800s, James Parkinson again described to 6 people. He saw some of them he saw as patients, others he just saw walking around, and coined this paralysis agitans, which is the name of the disease. Charcot came around later in the 19th century and kind of better defined the disease and gave it its name. Charcot was a famous French neurologist. And so the classic features is tremor at rest. So this kind of shaking, usually of one hand more than the other. Rigidity, so we move people's arms and legs around and head around and feel that stiffness. So the tremor, the rigidity. Bradykinesia or akinesia, that just means slowness of movement. And postural instability. So when I teach residents or fellows, we call it the trap of Parkinson's to help us remember the 4 cardinal features: tremor, rigidity, akinesia, which just means slowness, and postural instability. So we're trying to diagnose Parkinson's disease. That's what those main things that we use. Now when I see someone for the first time and I'm trying to figure out, is this Parkinson's disease or is this something else, there's some other features. So we look for those 4 cardinal features. Not everyone has all of them, but we look 2, 3, or maybe all 4 of them people have. Generally, the age of onset's around 60, but if someone comes in and they're young, 10% of people get Parkinson's before the age of 40. So oftentimes, those of us who do this for, do Parkinson's disease for a living, a lot of people will send us their younger patients. This guy looks like he has Parkinson's, but he's too young. Not true. You can be pretty young and still get Parkinson's. You can actually be too old to get Parkinson's. Most people who get Parkinson's disease over the age of 80 or 85 probably have something else. So that's something that we keep an eye out for. Somewhere between 5 and 20% of people have a family history. It's more common in men than women. And then some other things that happen. Before people even get a tremor, before they even get slowness or any of those cardinal features, they can suffer from anxiety or constipation, lack of sense of smell, acting out dreams where people will flail around and kick in the middle of the night during sleep. And these are all things that kind of help us to make the diagnosis because these are things that are associated with Parkinson's. Then one of the most important things is, does someone respond to Parkinson's medication? It's kind of circular reasoning. So if you respond to Parkinson's medicines and you get better, we're fairly certain that you have Parkinson's disease. But if that response is kind of weak, it doesn't last, or it's kind of atypical, we start getting worried about other things. And so there's a variety of other things that mimic Parkinson's, and they're listed here. Things that you probably have never heard of. They're pretty rare. But progressive supranuclear palsy, multiple system atrophy, cortical basal syndrome or cortical basal disease, essential tremor, vascular Parkinsonism. This is something that older people tend to get. Again, if people get diagnosed with Parkinson's after the age of 80 or 85, and they have mostly walking problems, we worry about something called vascular Parkinsonism. And then dementia with Lewy bodies is something that's kind of halfway between Parkinson's and Alzheimer's. There's a lot of thinking and memory problems along with the Parkinson's features, and that comes along very early, and is also accompanied by hallucinations very early. So even before anyone takes any medicine, because the medicines can cause hallucinations, people will have these hallucinations. So we look out for these red flags. When someone we think has Parkinson's but they don't respond to medicine properly, we start thinking maybe the diagnosis was wrong. So we have all these things when we're trying to diagnose Parkinson's disease, but we're only accurate about 3/4 to 95% of the time, especially very early on in the disease. So I was part of a couple trials where we would take patients the second anyone thought that they might have Parkinson's. They might have just a little trace of a tremor or a tiny little bit of slowness or something, and we would say, okay, we're going to diagnose them as Parkinson's, and we're going to follow them and see if they really do develop Parkinson's. And all these experts from all over the country, I guess not the world, the country, did these studies, and very, very early on, the accuracy rate's about 80%. So I had 2 out of 12 patients who I thought had Parkinson's. Turned out they didn't go on to develop something that was more Parkinsonian-like. And after a year or 2, we all knew it. It's just very early on, it can be very difficult to make an accurate diagnosis. And so these are the reasons why we need help. Even those of us who do this every day, all day, still get it wrong. So what do we have? So there is something that's relatively new, something called a DAT scan. And what a DAT scan does, it's a type of brain imaging study. It's kind of like a CAT scan, but it uses a radioactive label. It's something that's a derivative of cocaine, actually. It gets injected into your vein, and then a few hours later, the scan is done. And if there's asymmetry, in other words, this is a normal scan. This is an area of the brain. This is where, when I showed you that diagram, those the substantia nigra, those dopamine cells were dumping dopamine onto that area of the brain. That's this area here. So this is a normal scan. Hopefully you can see that pretty well. Both sides kind of look like a comma, and both sides are about equal. Over here, this is an abnormal scan where one side's a little bit brighter than the other, and it's kind of round. It's lost that comma shape. And that's an abnormal scan, and that correlates with having Parkinson's disease or something that's related to Parkinson's. That's where it gets tricky, because even if you have an abnormal DAT scan, It doesn't mean that you have Parkinson's. So the FDA only approved it for one purpose. And that's if a person has essential tremor. And essential tremor is what Katharine Hepburn had, if you remember, on Golden Pond. So both of her arms shook, and her voice kind of was quaky. And she probably had a family history. And when she drank alcohol, the tremor got better. That would be essential tremor. That has a normal DAT scan. So if we're trying to figure out the difference between someone who has a big tremor and is it Parkinson's or essential tremor, we can use this scan. It's not that useful for telling us other information. I don't get it too often. I've used it in the past in research studies. The study that I mentioned earlier, we were using this scan to figure out whether or not the doctors were right early on. This was part of PPMI, which is a Michael J. Fox big trial looking for biomarkers for Parkinson's. So we have this out there to help us. And it's been in Europe, I think, since 2000, yeah. And it's been in the US. It was used in research studies further back, but it was approved and started use for everyone in 2011. So just to touch base real quickly, what's up in the future to help us diagnose? So one of the things I'm most excited about is other imaging modalities. So many of you have probably had an MRI scan of the brain. The going theory is that really if you look at the MRI scan in someone with Parkinson's disease, it's pretty much normal. And most radiologists can't tell a difference. But if you use particular types of scans, and particularly stronger magnet strength, so there's a magnet in there, that's what the MRI, the M is for magnetic. There's ways of figuring out whether or not a person has Parkinson's and whether or not their Parkinsonism is truly Parkinson's disease, or maybe it's one of the other red flags. So this type of imaging isn't available yet, but there's a lot of studies that are really focusing on this, and I think this is going to be very important in the future. The other thing that's been really exciting and kind of made a splash in the news a few years ago is synuclein staining. So if you remember what that Lewy body looked like, and it was stained for a protein called synuclein. So synuclein, and we'll talk a lot more about that today, is a marker for Parkinson's, and probably, in a sense, is the cause of Parkinson's disease. So what has been found, and this has been looked over years, is that this one group looked at colonoscopy biopsies. So people go in for their routine colonoscopies, age 50, and they go in, go through the whole prep, and biopsy samples are taken. And what this group did is they looked back at these biopsy samples and found that all of the Parkinson's disease patients they looked at had this abnormal protein in the colon biopsy. So pretty cool. So if a person goes for a colonoscopy and they're in there looking for colon cancer or polyps or something, you could conceivably take a sample, stain it for synuclein, and figure out if that person has Parkinson's. Or even more interesting, there were 3 patients in this study who didn't have Parkinson's disease when they had the colonoscopy. So the colonoscopy predicted that they were going to develop Parkinson's disease. So again, very, very exciting stuff. The problem is there was a review of all the different biopsy studies came out a few months ago by a group in Canada, and they looked at all the different studies, and you really got to know what you're doing, because most of the studies weren't nearly as accurate as these were. So 9 out of 9 Parkinson's patients had abnormal colon biopsies. 23 people without Parkinson's had normal. That's fantastic. That's amazing test results, but not everyone could replicate it over the years. So I think we need more work to figure out whether or not this is truly going to be a way to diagnose it. But it certainly could be in the future. The other thing that the same group did, who did this study, also this came out very recently, the understanding that if you look at the bacteria that live in the gut of people with Parkinson's, it's different than those who don't have Parkinson's. And they the group that did this looked at all the types of bacteria and thought that maybe the type of bacteria actually predicts and may even cause Parkinson's disease, because this bacteria causes a lot of oxidation. It causes what could be misfolding of proteins inside the GI tract. There's a theory that proteins in the GI tract get transferred back up to the brain and cause Parkinson's. It's a theory, don't know it for certain, but it's just kind of an interesting fact in that way. And also, you can imagine if the bacteria change happens before Parkinson's, and you can check a person's bacteria in their gut, and if it puts them at risk, there may be a way to change that, to change the bacteria. So it would be a way to prevent and to diagnose Parkinson's. So the synuclein protein, you can also look in other areas, and there's a bunch of studies looking at that. The one that I kind of thought was interesting, there's one where they do a biopsy of the salivary glands down here. Those of us who do movement disorder, we know a lot about these salivary glands because we inject them with Botox to dry people up when they're drooling too much. So you can take biopsies of that, and in some cases, looking for that same abnormal protein, that synuclein, you might be able to make the diagnosis. There have been a variety of other studies looking at skin biopsies, and some of these have been amazingly positive. You take skin, you look at it, you stain it for synuclein. If it's there, a person has Parkinson's. But not everyone can do it perfectly well, it seems. There's a lot of variability. So much like a lot of the stuff that I'm going to talk about that's in the future, it hasn't really been worked out yet. But it's stuff that I think is interesting and is on the horizon, something to keep an eye out for. So there's a bunch of other things that are going to end up being what we call biomarkers or ways to predict or diagnose Parkinson's disease. A lot of them are just people take spinal fluid out, they look at the different proteins that are there, blood samples, urine samples are being looked at, whole variety of ways. But the one that made kind of a bit of a splash recently is one that was a collaboration using patients that were enrolled in PPMI. So that's, again, the Michael J. Fox study, the Udall Centers, which are a band of Parkinson's research centers throughout the country, of which Johns Hopkins is one. Also, the National Institute of Health was involved in this as well. And they came up with this algorithm, this set of questions and tests. So they would ask a group of people, how's your sense of smell? Do you have a relative with Parkinson's? How old are you? Male or female? And then along with those 4 questions, they looked at the genetics of those people. And there are 30 different risk genes that they looked at. And by compiling all of this information, they were able to identify 83% of people who have Parkinson's disease without ever doing a physical exam. The problem is, Parkinson's is a pretty common disease, but not that common. And if you do the math, if we gave this test to every person in the United States, we would identify 1 person with Parkinson's disease and misdiagnose 6 other people. We would tell 6 people they have it for every 1 person that we got it right. So the idea is, we know this is pretty exciting, if you find people at risk for Parkinson's, maybe there may be a little subtle finding, maybe they have a particular genetic background where you can apply this test and figure out whether or not they're at high risk. But you can imagine one day down the road when we understand the genetics better and we understand some simpler questions, we may be able to come up with basically a questionnaire and a blood test to be able to diagnose Parkinson's. So those are kind of the things that I just wanted to touch base on when it comes to the diagnosis. I wanted to take a break here. We're going to have 4 of these little sections. So this was section 1. So in order to keep everyone a little bit awake and to give my voice a little break, what I thought I might do is see if there's any questions, anyone have any comments, anything they'd like to add. Happy to hear from you. It's more fun when it's a discussion, I think. Please.
My mom is the patient here, and I have a sister also. But my mother has a problem with constantly dry mouth, but drools all the time. Is that common?
It is, and so I'm going to talk a little bit about treatment. So what happens, and I'll touch base, when they talked about the biopsying of the salivary glands don't work. And so people don't work as well. So people actually with Parkinson's produce less saliva than they're supposed to. Now I say that, and most people say, you're crazy. I got way too much spit in my mouth. What happens is people's automatic response or reflex to swallow doesn't work. They basically don't swallow their spit. So although people make less, they have excess there. And so our site's doing a trial to do injections to try to reduce the drooling. The drooling, people can choke on that, so it's a big deal. There's a couple pills, there's drops, and there's injections that all can help with that. And we use all of them. Anybody else? Yes?
Trouble dealing with excessive heat and not being able to see and light flashing around your eyes. Is that a Parkinson's thing?
It can be. So sometimes with People get a little bit lightheaded, sparkling in the eyes. That can be actually from low blood pressure. That can happen not only just with Parkinson's disease, but also on top of it with the medicines. And I have a lot of my patients will do stand up, sit down, and lying down blood pressures to see if there's big sways in blood pressure. The heat intolerance, I hear that a lot, so some of the medicines can do that. Amantadine is notorious for causing heat intolerance. But there's also something with Parkinson's, especially a little bit later on in the disease, called autonomic instability. People don't control their body temperature, the way the blood vessels open and close in the periphery to make you flush. You may not sweat as much as well. So that, kind of throws you off kilter. So that can cause those problems. The sweating can be excessive when a person wears off. So if they're on levodopa and the medication's nearing the end of time, you can get really excessive sweats. It happens a lot overnight as well. So those things, so I guess the answer would be yes. I wouldn't look for other reasons, but it certainly can happen with Parkinson's. Yes?
I see in this bullet, last bullet, it talks about that H5N1 bird flu leads to kidney-like changes in mouse brain. Okay. Do you have any recommendation on flu shots?
Okay, yeah, so this is going to be the next part of the talk is about causes, but there's absolutely no reason not to get the flu shot. I encourage people to do that.
Well, with the stomach bacteria, or the gut bacteria, would it be beneficial or helpful to take probiotics?
I don't think the studies, there's really studies to support that, so I don't really have evidence to say yes or no. I think probiotics is it was very trendy. I think it's even trendier in Parkinson's disease nowadays. We worry about the bacteria inside the GI tract when it comes to absorbing levodopa as well. So we don't really know what to make of the information that I just gave you. No one really knows what to do about that. It's just kind of a theory. H. pylori, which is the bacteria that can cause ulcers, has been shown to interfere with the way levodopa is absorbed. So when people treat that H. pylori infection, their Parkinson's seems to do better. So that would be kind of a reason to have good bacteria in your GI tract. But whether probiotic is really helpful in Parkinson's, I think there's a lot of nutritionists that would tell you so, and probably a lot of Parkinson's patients who might. But I don't know that there's studies that support it, none that I know of. No, all the junk food. No, obviously you're gonna. People say, is there a Parkinson's diet? And there's certain things you think about. So high protein can interfere with levodopa transport. So when it comes to diet, you have to kind of know that if you're eating something with a lot of protein, it may actually reduce the effectiveness of that particular dose of medicine. High-fat meals tend to slow the GI tract down. So for some of the medicines, that prolongs their effect. For other of the medicines, it slows down to the point where you get what's called dose failures, where if you have a high-fat meal, sometimes the medicine doesn't work that well either. So, small meals, Mediterranean diet, all the things that, that sound good for your heart and to prevent stroke and blood pressure, for the most part, that goes along with Parkinson's. The one change is sometimes people have very low blood pressure. And so the low salt recommendations kind of get reversed. So we tell people to eat more salt, whereas Dr. Oz is telling you not to eat salt. So, yes?
Do you know any stats on people whose parents have had supranuclear palsy and Parkinson's?
Yeah, so there are genes, and I'll talk a little bit about that. There are genes that can, in one person, give them PSP, and then in another family member, presumably, can cause Parkinson's. So that's more in an experimental phase, but LRRK2, which I'll talk a little bit about, there is some evidence that people who have the mutation in LRRK2 may have something that looks like PSP, and then others had something more like Parkinson's. It's one of the problems is it's hard to do those studies because, was the Parkinson's misdiagnosed? Was the PSP misdiagnosed? How sure are we? So you want to have sort of autopsy-proven diagnoses in a family that has a known genetic mutation, so it becomes hard to get good statistics on that. I can tell you that I have a couple of patients with Parkinson's who have told me that they've had a relative who was diagnosed with PSP, and then there's a whole PSP literature out there, which I'm not going to talk about, that is implicated in a variety of different Parkinsonian disorders. So it kind of depends on how we define it, but there's clearly Parkinsonism that can run in the family, some of it looking more like PSP, some of it looking more like Parkinson's. Some of it we can test for, most of it's still in the research phase, so those tests aren't available.
When my mother was diagnosed with total, here are all her medications and diagnosed her University of Maryland in Philadelphia.
So, you know, statistically it's possible.
That's pretty rare, isn't it?
Yeah, that's it's also a hard thing to do. So Stephen Rich, who's at University of Maryland, he's pretty good when it comes to PSP diagnosing. So if he was involved with it, I'd have a great deal of confidence in that. We do trials in PSP, so we're pretty good at it. But I have certainly seen people who've had Parkinson's disease for a long period of time whose eye movements mimic those you see in PSP. So you have to be careful. It's a tough diagnosis, and certainly tough to make a double diagnosis.
Could you explain what PSP is?
Okay, so if you've so PSP has the celebrity for PSP is Dudley Moore. So if you've seen the movie Arthur, so he suffered from this disease. It's Parkinson's-like. The progressive supranuclear palsy has to do with eye movements. That's where the name of the disease comes from. Eye movements, it's very difficult for a person to look down or look up. They tend to be very sloppy eaters. They have a lot of trouble with stairs. They tend to fall backwards. And they look like they have Parkinson's, but when a neurologist examines them, there's something not quite right. They have a lot of stiffness in their trunk and in their neck, whereas their limbs tend to be pretty loose. And if you give them levodopa, they don't respond quite as well. And sometimes hardly at all, the way a Parkinson's patient does. So that's one of those red flag diseases where I said if a person doesn't respond to medicine, we worry about that particular disease. All right. One more sip of water. Any other questions about diagnosis? Yes?
So there really is no medication for that, because the new doctor doesn't cover it all, doesn't put it to sleep.
I'm sorry?
It puts her to sleep.
Yeah, so, you know, Parkinsonism, so people with Parkinson's disease have Parkinsonism. So Parkinsonism just means that you look like you have Parkinson's. So people use the term Parkinsonism because they don't want to say Parkinson's disease because something's fishy, and they're not sure what. It could just be an unusual case of Parkinson's, and you just have to find the right combinations of medicines. But it could also be any of those other diseases that I described too. And there's a list of those. So MRI scans can sometimes figure out the difference. People get spinal taps sometimes to figure out the difference. There's a variety of different tests to look for what the cause might be. Some of the diseases do respond to medicines other than Parkinson's medicines. So there's a medicine amantadine. I use a lot of that in Parkinsonian syndromes and multiple system atrophy. There's a variety of other medications that can treat some of the sleepiness and dizziness and unsteadiness that occurs with that disease that doesn't work quite as well in Parkinson's. So again, it's a matter of, usually it's a trial and error type thing because there's no clear approved medicine to treat the conditions, but we try things. If something works, we stick with it. If it doesn't work or causes side effects, we move on.